So good evening, ladies and gentlemen, and welcome to this webinar on role of ultrasound in management of rheumatoid arthritis. My very sincere thanks go to Dr. Nidhi Prakash, the President, Delhi State IRIA, and Shalini Thapar, Dr. Shalini Thapar, who's Secretary for Delhi State IRIA, and as Dr. Atin said, the Nari Shakti. So thank you very much for this warm invitation. It's my honor and privilege to address such an august audience this evening. Can you help me here? Why is my screen not moving? All right, yeah. So rheumatoid arthritis, as we all know, is a chronic inflammatory immune-mediated systemic disorder, and it involves joints classically. The past decade has seen several advances in ultrasound, imaging, and evaluation of joint damage and inflammation in rheumatoid arthritis. How applying this ultrasound in the diagnosis of rheumatoid arthritis has completely transformed the clinical practice will be the key aim of this presentation today. So coming to the choice of cross-sectional imaging, despite MRI being the gold standard in early stages of RA diagnosis, we're also familiar with the advantages of ultrasound over MRI in routine clinical practice. The advantage of dynamic grayscale scan combined with that of the power Doppler and microvascular imaging wins over in the following ways. So at the time of the presentation, in quicker staging of the disease, faster staging, during the course of the treatment, the monitoring of the disease status through multiple reviews that are not too heavy on the patient purse and patient's pocket. Unfortunately, that's what MRI lands up into. Assessing the efficacy of the treatment response vis-a-vis the response through either we have the remissions or the exacerbations, and assisting in the research work, which is absolutely important because this is a very new subspecialty that is coming up and it's continually modifying. Then, of course, the interventions, which are ultrasound guided, and we all know the advantages of those. Aspirations, synovial biopsies, or giving targeted steroid injections, or the PRPs for the treatment. And last but not least, of course, in post-surgical evaluation, as we can see here, where there are implants that have been put, and they sometimes interfere very deeply when we are doing an MRI, but in ultrasound, these rigid bioarticular implants do not interfere with the quality of imaging. And these are here at the metacarpophalangeal joint in a wrist and hand radiograph to prevent joint space collapse. So this is just an example how ultrasound today helps enormously in the evaluation without too many artifacts that actually interfere with the imaging. So there's no general consensus on which joints to image for diagnostic purpose, and this is definitely a carry-home message that I want to bring. Symptomatic joints should be targeted first, followed by study of all the joints which are typically involved in RA and have been documented, even if they are asymptomatic. Specific small joints such as metacarpophalangeal joints, proximal interphalangeal joints, radiocarpophalangeal joints, and also metatarsophalangeal joints, which are superficial. So they allow access to the synovial surfaces, which are very superficial and all around. They are recommended by UNAR and OMRAT. All larger joints, of course, can be assessed. So, of course, we can go ahead and do for knee if it is symptomatic, ankle, which is involved sometimes, and shoulder. However, the limitation is that the scan of these joints gives suboptimal results due to a low frequency of involvement. They are not as frequently involved in rheumatoid arthritis as the superficial joints, such as of wrist, hand, and feet. And there is still a lack of standardization for the optimal views. The larger joints are deeply positioned. So sometimes there is a lower sensitivity of bringing on the power Doppler signal detection. Yes, cartilage involvement is much better seen when it is a large joint involvement, by ultrasound. However, the most important feature, that is, we are talking cortical erosions, have a very low yield when we are talking about the large joints. So moving on to the technique, well, we are all radiologists here. I don't think I will go into deeply into how we need to do. We usually use a hockey stick probe, which is a high frequency, small footprint, and the higher the better. We used to be talking about 712 megahertz, but today we are using 19 megahertz also for very superficial extensive surfaces of the hands. Of course, the comfortable positioning of the part that you are imaging. The important part is that it should be a multi-level. Multiple levels of investigation needs to be done in orthogonal planes. Minimal pressure needs to be applied so as not to obliterate the small effusions or the small vessels when we are performing the power Doppler study. The important factor here is that there has to be a side-to-side comparison, which is absolutely mandatory. And for power Doppler interrogation of suspect synovitis, the filters that we should set should be for very low velocities. So, stages of RA. Now, this is something, these have been postulated and there have been multiple modifications. This is the simplest that I'm bringing to you. So as you understand how we have a clinical radiological correlation. So it must be also understood that the progression through all the stages can take many years. So I'm talking stage 1, stage 2, stage 3, stage 4. It can take many years for it to evolve from stage 1 to stage 4. And some patients do not even progress through all the stages within their lifetime. And each stage of rheumatoid arthritis comes with a different treatment plan, different treatment goal. And since there is an even greater need for us to accurately stage and report the rheumatoid arthritis when present. Now, stage 1 is where they have synovitis with or without inflammation, giving classically that early morning stiffness and discomfort. Diagnosing rheumatoid arthritis actually should be at this stage. The next is, of course, stage 2, which is a moderate stage. And at this level, the cortical erosions and the cartilage damage starts. As a result of which, there is that minimal functional disability. This is the stage actually at which most of the patients present because there is a functional disability now also along with pain and swelling. Stage 3 is when, of course, treatment plan becomes extremely complex because it is a severe form, advanced bony erosive changes come, muscle weaknesses come, and the deformities start setting in. And stage 4 is, I don't think we talk about it because this will be that final place where there's so complex a presentation. There are subluxations and hyalosis, tendon tears, and multiple levels of disabilities that set in where I think the clinician would know immediately what they need to do. They won't need to send the patient for an ultrasound. So the role of the radiologist is to document these early manifestations much, much before the bony changes, that is the erosion start happening. And that is the main aim of every clinician to prevent the progression, which tends to become then irreversible disability. The sono signs have been broadly divided into extra-articular signs and intra-articular. So when we are talking of extra-articular, we are talking of tenosynovitis, bursitis, enthesitis, synovial cysts or ganglions, rheumatoid nodules, vasculitis, myopathies, and cardiovascular diseases. When we are talking of intra-articular, we're definitely talking of synovitis. That synovitis, which is showing activity and inflammation in form of hyperemia. Then we're talking of bony destruction or bony erosions. Those are cortical erosions, joint effusions, cartilage changes, and joint space narrowings. We've gone through everything, but the bitter truth is that no one particular sono sign is pathognomic of rheumatoid arthritis. Hence, a combination of these sono signs put together with the clinical signs, clinical interpretations, and the biomarkers go on to give a much higher specificity for the diagnosis of this disease, particularly when we are talking in early stages. So many scoring systems have been proposed, out of which we are going to be talking about the 3 main ones, and they need a particular mention. So the first one, of course, is the 7-joint grayscale ultrasound, which we call as GSUS. Power Doppler Ultrasound, PDUS scoring system, and this was suggested by Backhouse and is today the most popular. It's a 7 joints of hands, wrist, and feet. And there is a gradation that is given on the qualitative and semi-quantitative basis of the soft tissue changes, which we've just now discussed, synovitis and tenosynovitis, and the bony changes, which are erosions or further destruction, which happens at the level of the joints. And these are the main solar markers. Now, the next one, of course, is SOLA, which is also called a sonography of large joints. And this is more applicable and is used more frequently for the ankylosing spondyloarthritis and psoriasis. And this is semi-quantitative sort of gradation or classification, and it's based only on presence of synovitis and effusion in the joint. Then, of course, they brought a 4-grade system to ease it off, which is a modification over the SOLA, and it has very limited diagnostic confidence. So our discussion today will be centering around the 7-joint assessment of rheumatoid arthritis, which is proposed by Backhouse. So how many joints? How many joints do we examine? So that no evidence-based consensus has been able to point at an ideal number of joints that should be scanned. As high as 78, I remember, were also being proposed at some time. That, of course, increased the sensitivity of giving the diagnosis, but you can just imagine how long that ultrasound must have lasted. So the concept of limited exam is proposed by Backhouse, which we have already mentioned, the 7-joint grayscale power Doppler ultrasound scoring system. And this was then applied to the routine clinical practice. The joints to be scanned protocol-wise are dominant hand, wrist, both on dorsum and the ulnaris aspect. That means we are talking the dorsal recess and the volar recess. Then we have the metacarpophalangeal joint of second finger, metacarpophalangeal joint third finger, proximal interphalangeal joint 2, proximal interphalangeal joint 3, and then in the fifth feet we have metatarsophalangeal joint 2 and metatarsophalangeal joint 5. And this is so that it was found through multiple RCTs that the yield of finding the synovitis and cortical erosions is highest in these joints. Now, Aga et al. Was another group, task force group, and they added evaluation of 2 tendons, the extensor carpi ulnaris and tibialis posterior to it. Power Doppler ultrasound was most useful for the dorsal recess synovitis at the wrist. That means not only the grayscale, but even the power Doppler lifting evidence was much higher when we were dealing with the dorsal recesses of the wrist. And for cortical erosions, it was suggested that the metatarsophalangeal joint 5 was most sensitive. For a quick, like if the patient is come, you are short of time, patient is short of time, a quick recce of for the early disease, a focused joint, if we start with the second and third metacarpophalangeal joint, and the third proximal interphalangeal joint has the highest yield and will actually give you a direction where you need to go. And so the targeted focus scans, metacarpophalangeal joint 2, 3, third proximal interphalangeal joint, and of course, mandatorily, you're going to be scanning both the hands at the same time, I mean, one after another. So ultrasonography has proven to have a high reliability index in diagnosis of rheumatoid arthritis. Solar signs being, again, synovitis, increased vascularity, that means we're talking hyperemia, tenosynovitis. So we have practically 2, synovitis and tenosynovitis. These are 2 soft tissue markers. And then we have bone erosions, which is a third bony change. Now, synovitis on grayscale and hyperemia on a power Doppler ultrasound has been scored on a scale of 0 to 3, and it's a semi-quantitative scoring. Tenosynovitis and cortical erosions have been scored on a qualitative index. That means present or absent. So if it's absent, it's scored 0, and if it's present, score 1, and that goes for the cortical erosions as well. And there have been studies which say that the 7-joint GSUS power Doppler ultrasound, which was given by Backhouse, correlates, compares very well to the clinical DAS. That means the disease activity scoring system that the rheumatologists have, and they take 28 joints. So it compares very well to DAS with ESR or with CRP, and also with the laboratory data in rheumatoid patients. So a quick run through. Now we will go on to the sono signs. So on a grayscale ultrasound, how do we grade the synovitis? Grade 1 is when there is a very small hypoechoic, thin hypoechoic line you see beneath the joint capsule, and this is then given score 1. Grade 2, there is a joint capsule elevation. That means there is a distension of this capsule. However, it still remains parallel to the joint line and is given score 2. Grade 3 is when there is a convexity and a great distension of that capsule, which on eyeballing, you don't have to really say anything on eyeballing. You can say that this is a synovitis of grade 3. So in easier terms, grade 3 is when the synovitis is extending both proximally and distally to the joint line. And grade 2 is when it is extending only proximally. That means it is actually following or flowing over the metacarpal and not going actually into the proximal phalanx. So coming to the sonar images, this is a long axis scan, a grayscale imaging, as you can see, of the dorsal aspect of metacarpal phalangeal joint, and is showing this thin line. It's a very thin hypoechoic, echogenic line of synovitis, which is underneath the joint capsule. And you can actually feel that there is a kind of convexity. It's really not as distended. So there's no capsular distension. However, you can see that that synovitis is spilling over partly into the proximal phalanx. Now, this was just one of the unusual cases where it was coming as grade 1 synovitis. Underlying hypoechoic cartilage, as you can see here, at the metacarpal head was well maintained. An even thickness, joint space is maintained, and the smooth articular surfaces, no vertical erosion. So this goes in favor of synovitis of grade 1. Grade 2 stage, where the synovitis is minimally distending the capsule. So you can see that the capsule is distended. It's an obvious sign here. This is, of course, on the extensor surface, metacarpal and the metacarpal phalangeal joint here. It is showing mild synovial proliferation, but no erosive changes. And the smooth vertical surfaces, there appears to be a small vertical erosion that has started developing at the level of proximal phalanx, but the cartilage seems to be sort of maintained bit of irregularity, but this was like done by a 12 megahertz probe. Had we had a higher frequency probe, maybe 19, then we would have been able to really justify whether there is a cartilage erosion, cartilage irregularity, or loss of cartilage at this point. And of course, then we have grade 3 synovitis on grayscale. We really don't have to explain that. This is quite self-explanatory, that there is a spill over the metacarpal, and it's going over the proximal phalanx as well. A lot of vascularity here, and this could have been tested out. Anyone can ask whether it's not fluid or complex fluid. So you do your compressions with the probe, and we can always say that it's compressible, but partly compressible but not displaceable. We are talking about synovitis. If it's compressible and displaceable, then we're probably talking about complex effusion. This is just another of the companion cases here, where you can see that it is spilling over on both the sides. So grade 3 synovitis on grayscale imaging. Coming to the power doctor ultrasound, which actually is the mainstay of evaluation in rheumatoid arthritis, because Doppler ultrasound, it allows detection of the perfusion of synovial tissue in inflammatory disease. The presence of Doppler signals represents a prognostic criteria for development of erosive disease in rheumatoid arthritis, which has been defined by Omerat. So when we're talking grade 0, we're saying there is no intra-articular vascular signal on power Doppler, but there will be on grayscale, we will have synovitis. That's why we put the power Doppler there. Grade 1 is when the intra-articular vascular signals are seen, but they are less than 3 in number. Grade 2, when the signals and the vascularity is involving less than 50% of the total intra-articular region. And of course, grade 3 is when the intra-articular flows are florid. They are occupying nearly every area of that joint. So it was a study by Yoshimi et al., and they documented that the best region for assessment for the vascularity, synovitis, is the palmar side of the wrist. And the take-home message here is that when the patient is in true remission, so we know that the patient is of rheumatoid arthritis, but when he comes and we find that there is GSUS 1, but power Doppler is grade 0. So power Doppler grading has to be 0 for us to say that we are dealing with a remission. So bringing again on the power Doppler sono images. This is, of course, where we have the on grayscale study synovitis of grade 1. But when we put our color map, we found that there was no Doppler signal that was coming. So that falls into the category of grayscale imaging, grayscale ultrasound 1, but on power Doppler ultrasound, the grading goes as 0. So no vascular signal. Now, this can be a normal finding in a patient. Sometimes, yes, patients do walk in, they are having this. Please do not label these patients as imminent rheumatoid arthritis. It can be an evolving pathology. So, of course, we have to go in for reviews. And this could be a patient in remission. So, you need to have a history that is the patient on some sort of DMARDs, disease modifying, NSAIDs, or maybe steroids. Here is when we have power Doppler ultrasound giving us grade 1 scoring. That means this is on the extensor aspect of the radiocarpal joint. And of course, the tendons that you can see here, mild synovitis, but when we put on the color Doppler in the radiocarpal joint space, we found that these signals were there, and this was labeled as grade 1 of the power Doppler ultrasound. Coming to the long axis image at mid-dorsal recess here, and it is associated with moderate isoepic synovial proliferation, which is consistent with grade 2 power Doppler, where you have, there are no signals that you can always ask why are there no signals here, and that was because this was complex diffusion. On compressibility, we could displace this fluid, but there was synovitis, and this is partly involving about 50% of the intra-articular region, and this went into grade 2 power Doppler, but it is a grade 3 on grayscale ultrasound. So grade 3 of GSUS, but grade 2, I'm so sorry, this is a grade 2 here of power Doppler ultrasound. This, of course, I don't think we need quite a bit of thought here. There is isoepic synovial proliferation, lots of florid vascularity, not only on color Doppler imaging, also on power Doppler imaging, and this was scored as grade 3. Now, this was just one of the studies that was brought by Carol et al., and they reported that, see, those were all qualitative indices. So, can we quantify the vascularity and indicate what are we dealing with? And we found in studies that the resistive index is defined, and if this resistive index is less than 1, indicates inflammation, but if it is less than 0.48, it is strong predictor of inflammation, which is of rheumatoid arthritis. So quantification of inflammation in the synovium was the next step that came through to enhance our diagnostic ability to diagnose early rheumatoid arthritis. So now just a quick run through here. We are having grade 2, less than 3 power signals, involvement of 50% of the intra-articular region, and of course, complete florid state. If it is grayscale greater than 2 and power Doppler greater than 1, we are dealing with active synovitis. But with the grayscale 1 and power Doppler 0, then it could be normal, it could be an evolving, or it could be a patient, a known patient of rheumatoid arthritis in remission. A very strong and a very important sono sign of moderate rheumatoid arthritis is cortical erosions. And these are predominantly seen on the radial aspect of the metacarpals and of the phalanges. Bone erosion is a central feature of seropositive rheumatoid arthritis. and it is associated with disease severity and poor functional outcome. Now, here is a long axis scan, and on the metacarpal head, you can see a conclusive evidence of erosion. Now, there was a classification that was proposed by Wang et al., and he defined 4 stages of cortical erosions depending upon the morphology. So there is a continuous cortical margin, then grade 0, but then there is a surface irregularity, but there is no obvious bony defect was given grade 1. Then there was a cortical bony defect, where in 2 perpendicular planes, as you can see here, 2 perpendicular planes, you could see the cortical erosion was grade 2, and then of course, extensive bony deformities and defects, altering the entire joint configuration was grade 3. This kind of had a sort of fence sitting here, if there was under or over estimation. So another grading system was brought by Backhouse again, and he said that grade 0, no erosion, and grade 1, when there is, and this is a kind of quantitative assessment, so grade 1 was less than 1 millimeter of the size of the cortical erosion, grade 2, 1 to 2, grade 3, 2 to 3, grade 4 was greater than 3 millimeters, and grade 5 when there were multiple bony erosions. Moving on to yet another sonocyte which reflects rheumatoid arthritis, we have tenosynovitis, whether of the extensor tendons or of the flexor tendons. And this is also graded qualitatively, that means present or absent. So if it's present, it is score 1, and if it's absent, then of course it's grade 0. This was just one of the cases where there was swelling of it was kind of swelling all around the wrist joint. And when we did the scan, the patient, of course, was carrying this X-ray, and the clinician was extremely perceptive and keen observer. They thought there was probably some sort of a change that was lying at the other aspect of the styloid. When we did the ultrasound, we found that yes, there were multi-level tenosynovitis, tenosynovial proliferation of around the tendons, and this actually went on because this was a grayscale study, which is grade 3 ultrasound score, and on the power Doppler, we could say that there was florid inflammation of the synovitis going into grade 3 power Doppler study. Again, a grayscale ultrasound image of dorsal recess of the wrist joint. Again, on grayscale study, you can see that there is an obvious proliferation of the synovium, which is, of course, grayscale 3. And of course, on power Doppler study, there was just a 50% of involvement, so this was grayscale 2. But what was more important was this small, tiny erosion that we could lift, and this was absolutely diagnostic of rheumatoid arthritis. It was a dead giveaway. Now, extensor tendons are more commonly affected than flexors. These are ultrasound images which are showing short axis scan of extensor compartment of the core. This patient had on the left side minimal, we could see that there was synovitis, but there was no power Doppler signal that we could raise. However, on the right side, it was well established with synovitis through the extensor compartment 4. And on color Doppler, of course, we were raising these multiple signals. Now, since there was, since we had no comparison because both the hands were involved, we took a kind of a control person, and this was an image of grayscale study which showed normal extensor compartment 4 versus left. So it was on comparison with the control that we could say that there was mild changes in the extensor compartment 4 on the left side. So grayscale scored 1, power Doppler scored 0, but on the right side we had grayscale 2 and power Doppler 2 and established rheumatoid arthritis. Of course, this patient went on to have other biomarkers also. Now, this is a grayscale long axis scan of the extensor compartment 6. That means we are dealing with now here extensor carpi ulnaris, and there is hypoechoic synovitis with no evidence of hyperemia. There were no signals that we could raise there. Extensor carpi ulnaris tendon is probably one of the earliest tendons to get involved in early stages of rheumatoid arthritis, and it sometimes can lead to erosion of the styloid process, as we have seen in the previous case. A thickened overlying, we thought that this was a thickened extensor tendon. However, Extensor retinaculum, excuse me. However, there is a study by John Jacobson who said that there is absolutely no involvement of retinaculum in rheumatoid arthritis. What happens is that since there is tenosynovitis, the extensor retinaculum that is present just above that tendon sheath may give a false impression of thickening of the retinaculum, but it is actually the tenosynovitis. So this is for your reference that extensor retinaculum should be like about 1 millimeter in thickness. If there is a thickening, do confirm that we are not dealing with tenosynovitis, and that's an important part of the evaluation. Coming to metatarsophalangeal joints, this is evaluated as a 7-score classification. Second and fifth metatarsal joints are most important for erosions, and first metatarsophalangeal joint for synovitis. Now here you can see in the left upper corner, there is a grayscale study, long axis, dorsum of the scan, which is showing anechoic diffusion at second metatarsophalangeal joint. Whereas here, what we see here is a synovitis and hypoechoic synovial thickening. Inclusion of tibialis posterior tendon by Aga and Rupert that we've already discussed with the 7-score system, which was devised by House, actually inspired me to go to the posterior tibialis tendon also, and you could see that there was a tendon sheath diffusion in the same patient. So we are really talking about very early stages of rheumatoid arthritis, and we are catching them young. Now, some of the associations of rheumatoid arthritis, we all know, I'm just going to stop this for a while here. So we all know that entrapment neuropathy, or we call compressive neuropathy of the median nerve, is a part of rheumatoid arthritis, which can happen because of the tenosynovitis of the involved tendons, flexor tendons, or there can be fluid within the carpal tunnel, or there can be synovitis between the intercarpal joints, or regular ulnocarpal involvement. And these all can involve the carpal tunnel. Increased cross-sectional area is the mainstay. So we talk about cross-sectional area, which should be somewhere around 11, less than 11 millimeters square. But we can also, if you want to go into deeper understanding of that, we can have a flattening ratio. And so flattening ratio should be greater than 2.5. And the swelling ratio, that is comparative between the two sides, you should have a greater than 1.4. So you have a higher diagnostic confidence to give a comparative study or median carpal tunnel syndrome. Now, pancreatitis is kind of inflammation, it's a previous fact, you all know, but this can be associated with vasculitis, particularly in patients of rheumatoid arthritis, relatively rare, but it can be. And this was a girl who presented to us with pain in the thigh. When we did on the symptomatic side, we found this focal area of inflammation. When we put on a color Doppler, you could see that it was like as if it was on fire. And then, of course, for clinical interest, we went on to do our elastography to see that there was a huge decrease, a loss of elasticity in the region as compared to the normal side. On deeper asking, we found out that, yes, at one time, she was labeled as having an inflammatory joint disease, but she discontinued the treatment. So very important, if the patient presents, do at least try and put it into some form of acceptance, into some sort of a diagnostic criteria for diagnosis of rheumatoid arthritis. Now, following this, we have, this was a patient who presented to us with this swelling. And she was a young patient, 24 years. The patient was having very confusing kind of symptoms. This was a painless nodule that was present. And when we did a scan, we found that it was complex fluid on compressibility. There was synovitis, complex fluid. It seemed like synovitis at that point and cortical erosion. So we aspirated, and this is what we drew. On our ultrasound, this patient was put on empirical antitubercular treatment, as you can understand. Now, after this patient, for 4 months, she took ATD and she came back to us again. And now this time on the forearm, she had this sort of swelling. And this time when we aspirated, we sent it for inflammatory markers as well. And we found that she was positive for the rheumatoid arthritis. When we're talking rheumatoid nodules, these are small nodules that are present in the subcutaneous region over the bony prominences. On ultrasound, they seem like they actually look like these hypoechoic, well-defined masses, and they can undergo necrosis. They can become infected, like in this particular case, but they don't have calcification. So every time you come across the nodules such as this, do try and think in, out of the box and not really going to the closest way, which we tend to do in India. This is an algorithm that was developed by the authors as a guide for use of ultrasound in diagnostic decision making. And this was not based on clinical study. Osteoarthritis has not been included in it, even though it causes synovitis. This definitely helps in increasing the diagnostic confidence. We all know that there is a huge overlap of sono signs when evaluating patients with undifferentiated inflammatory arthritis. So I do hope this has been given by Gurjeet Singh, and he's an Indian doing wonderful work in rheumatology. So I do hope that you will find the incentive to go through it every time you're scanning a patient with suspect inflammatory arthritis. So this is one of my last slides. There is evidence now that early introduction of disease-modifying agents, so we are talking really DMARDs, inhibits the progressive structural damage. So NSAIDs and steroids do not do that. They decrease the symptoms. They decrease the symptomatology, makes the patient feel comfortable, but they don't inhibit the structural damage or progression of the inflammation. And clinicians need this window of opportunity of early diagnosis. Therefore, they require very early indicators of the diagnosis and outcome in patients who present with the overlap of these symptoms. The aim is here to treat to target strategy. This is it's a kind of mantra for the rheumatologist, treat to target strategy. So what is the target? The target is to achieve remission, early remission. For us to help achieve early remission, we need early diagnosis so that the disease-modifying anti-rheumatic agents can be started within that window period of 3 months of the patient presenting to you. And this is where ultrasound steps in. A research article was a very interesting one called Seronegativity on Rise in Rheumatoid Arthritis. It was by Nancy Walsh. And this was published in 2020, okay? And it says, I'm so sorry, and it says that there is a decline in seropositive patients of rheumatoid arthritis. Now, can you imagine that there is a rise in seronegative rheumatoid arthritis? So it takes away that ease of early diagnosis of the strong biomarker that we call as rheumatoid factor. Now, early sono signs such as synovitis, tenosynovitis, with or without hyperemia, can step in to help the diagnosis and, of course, with the cortical erosions. When there are cortical erosions, I think we have really lost that window period. So we have to concentrate on synovitis, tenosynovitis, and hyperemia very strongly. The sign of remission, of course, is that the vascularity will be absent. There will be mild synovitis, no hyperemia, but there will be erosions that you'll be able to see from the previous disease progression. A review of the studies are recommended. These are like for high activity disease. We review a patient after every 3 months, for low activity disease or in remission every 6 months. And the final goal is to help minimize this disease activity, prevent joint damage so that we can stop the disability from happening. So the final takeaway is that musculoskeletal ultrasound today is considered complementary to clinical exam in patients with rheumatoid arthritis. Early diagnosis and aggressive therapy of rheumatoid arthritis alters prognosis very significantly. These are some of the references for you to carry back home. Thank you very much once again for your kind attention.